Hello, everybody. We're going to go through another 10 internal medicine review questions here. Again, I really like to focus on some high yield topics. You will run into questions on step 2 and step 3 that are a little bit more vague. And maybe in the future we'll get to some of those more lower yield concepts. But right now, in these preliminary review question videos, I want to hit on the very high yield topics that you will definitely be asked about on step 2 and 3. And many of these are going to be vignettes that you may actually run into on CCS. So it's going to be really important to know these concepts. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you who have already donated. All right, let's get started. We got a 28-year-old man coming into the ED by his roommate as he suddenly began complaining of shortness of breath while they were playing video games. The patient's unable to talk due to his current state. The roommate doesn't know if the patient has any medical history, but knows that he does not take any medications. On physical exam, you note there are multiple atrophic scars and velvety skin through which you can see a veiny appearance. Auscultation reveals a systolic decrescendo murmur at the apex. There is a jugular venous distension. Bibasilar crackles are appreciated. Blood pressure 92/68, heart rate 120, respirations 24, temperature 98.6. Which of the following is the most likely cause of this patient's condition? A. Papillary muscle rupture. B. Chordae tendineae rupture. C. Infective endocarditis. D. Acute myocardial infarction. Or E. Cardiac tamponade. All right, so this is one of those questions that harkens back to step 1. And step 3 is incorporating a little bit more basic science into the test ever since about 2015 or so. So you'll be expected to know a little bit more anatomy than you might want to. All right, so the answer here is B, chordae tendineae rupture. So what is going on here? This patient has a connective tissue disorder. Now, how do we know that? Well, first of all, you need to set aside his present condition, when you're approaching the test question at least, and take a look at what else is going on. It's going to give you some hints. They never tell you things. Occasionally there's distractors, but more often than not, when they tell you things that don't seem to relate, they actually do relate. So what stands out here? So the multiple atrophic scars, the velvety skin, and the skin is kind of see-through. There's a veiny appearance. We all have veins under our skin, right? But in some people, you can see it. And if your skin is particularly thin, you'll be able to see it. I'm sure you've dealt with older patients before, and you look at their skin and you can see all those veins. They might roll if you try to run an IV, but you can see them, and that's because their skin, through age, has gotten thinner. Well, this guy's 28, so you should not expect to see thin skin. But which connective tissue disorder gives you thin, hypermobile, flexible, stretchy skin? Ehlers-Danlos syndrome. Okay. So a connective tissue disorder, and this does not just affect the skin. This affects connective tissue throughout the body. And so what we know is that the chordae tendineae is connective tissue, and that is these patients are prone to this kind of rupture. Now, what may we have expected to see in this patient prior to this event happening? A mitral valve prolapse. Okay, and anyone who has a mitral valve prolapse, particularly with this sort of degenerative, or maybe not degenerative, but this pathologic condition, we would expect to potentially see a mitral valve prolapse. So people who have connective tissue disorders are prone to mitral valve prolapse. So what we have here is an acute mitral regurgitation, and this is because the chordae tendineae are essentially the support system for the mitral valve. And so once that goes, the mitral valve can no longer work and we get a mitral regurgitation. Now, as you know, a mitral regurgitation is going to be a systolic murmur. There's blood in the left ventricle, and when the heart contracts during systole, blood is supposed to be pushed into the aorta, but rather than that happening, because the mitral valve is open, if you will, blood will flow backwards, and that will be appreciated at the apex. That's the mitral area. So if you ever hear that there is a murmur at the apex, you need to think about a mitral valve issue. So this is a systolic decrescendo murmur that's going to be heard at the apex. And what's going to happen here, let's say here's your heart, here's your, I am not a good artist, by the way. Here's your left ventricle and here's your left aorta. Blood is going to rush back into the left aorta. It's going to increase left atrial pressure. And all of this pressure is going to get transmitted. So it's going to increase pulmonary pressure, leading to a mild pulmonary edema. That's why we heard the bibasilar crackles. And then that's going to cause right heart failure. All of this is going to happen really, really, really fast. So this is not like a chronic mitral regurgitation that happens very slowly and you see findings, nice findings on chest x-ray. This is going to happen very fast. It's fulminant. And so you're going to have a pulmonary edema and you're going to have a right heart failure. And that's what leads to the jugular venous distension. Left to their own devices, these patients won't make it very long. Eventually, these patients will go into cardiogenic shock. As we saw, this patient has a blood pressure of 92/68. So it's very, very important that we diagnose this promptly and have this patient sent off to surgery. Differential diagnosis here. So mitral valve prolapse can cause a mitral regurgitation, but it would not have such an acute presentation. Rheumatic heart disease is another thing that can affect the valve and cause a regurgitation. We don't expect that in this patient because we aren't given any history that's consistent with that. And we also have the abnormal appearance of this patient's skin. Infective endocarditis, we would expect to see a fever, trauma, no history. And then you can get an acute mitral regurgitation after an MI. That's going to be 3 to 5 days after the event. But this would be due to a papillary muscle rupture rather than a chordae tendineae rupture. So this was Ehlers-Danlos syndrome. It is actually a set of disorders, and it's characterized by, again, connective tissue manifestations. So joint hypermobility, skin hyperextensibility. These are the people that can take their skin and it just stretches like taffy. And then some tissue fragility. And the most common cardiac manifestation is a mitral valve prolapse. So on this patient, we may have heard that mid-systolic click if he had came in a week ago instead of today. Ehlers-Danlos syndrome is commonly confused with Marfan syndrome, and there are some similarities. Completely different pathophysiology. They're both connective tissue disorders, but Ehlers-Danlos syndrome has more skin manifestations. So that's where we really see the difference. And it's so obvious. When a patient has skin manifestations, it's staring you right in the face. Again, like I said, they tend to have that more transparent, thin, stretchable skin, whereas a person with Marfan syndrome, the skin manifestations are pretty much limited to striae. These patients, both Ehlers-Danlos and Marfan's, are going to have that hypermobility. They can have some skeletal issues like scoliosis, pec excavatum. You may see pec carinatum in Marfan syndrome. The difference is with Ehlers-Danlos syndrome, they'll have a high arched palate, and with Marfan syndrome, they're classically tall with very, very long extremities. I've got a friend who's got Marfan syndrome, and if you ever look at his fingers, they're like spider legs. It's crazy. Really look for that tall, long extremity description in a vignette that's pushing you towards Marfan syndrome. Both can have mitral valve prolapse, but again here, the skin manifestations pointed to Ehlers-Danlos syndrome. That could be a follow-up question where they give you a question like this, and they may ask you which of the following is the most likely genetic disorder in this patient. With Marfan syndrome, you can also more commonly see aortic root dilatation. That's going to lead to an aortic regurgitation. That murmur would be a diastolic murmur. And I think you should know what that sounds like. Marfan syndrome can also get a lens or retinal detachment, and they can get spontaneous pneumothorax. Not surprising, just because of their height. And with Ehlers-Danlos, they have a tendency to get inguinal hernias. That's kind of interesting. But when you think of its connective tissue that's holding all those guts in, it's not particularly surprising. This is where you'll auscultate. Don't memorize this. Just what you need to do is commit this to memory in a conceptual way. So know your auscultative areas: the aortic, pulmonic, tricuspid, and mitral area. Remember, the mnemonic: all physicians take money. Really important to know that the mitral area is at the apex, because if they tell you there's a murmur at the apex, then you know that there is something going on with the mitral valve, whether that be regurgitation, stenosis, or prolapse. Okay, question 2. A 32-year-old man coming into the clinic complaining of difficulty achieving and maintaining an erection for the last 2 months. He says that he's unable to achieve a full erection necessary for intercourse. He has a past medical history of generalized anxiety disorder, which has been managed with sertraline. He went off this medication 3 years ago when he got into a relationship with his now wife. He is not on any medication at this time. He doesn't drink alcohol or engage in recreational drug use. He had a normal routine physical exam last year. Physical examination and vital signs are normal. Which of the following is the best next step or best next question to ask this patient? A, are you and your wife experiencing marital difficulties? B, do you feel that you may be gay? C, do you have a family history of prostate cancer? D, how often do you use pornography? Or E, do you wake up with erections? And by the way, this is a two-parter. These come up on the USMLE. So you'll be asked to choose your answer. It'll tell you, are you sure? Is this your final answer? You can't go back. Kind of like Regis Philbin. Is this your final answer? And then you'll be given a follow-up question. So this is one of those. So this is classic USMLE. They will ask you, what do you want to know next? Because this is testing your clinical thinking, your thought process. And so when you look at these questions that ask you, what do you want to know? What's your next question for the patient? That's what they're getting at. And you'll look at all the answer choices and you may think, well, I want to know all of these. Like, of course I want to know if somebody with having difficulty with an erection is watching porn. Of course I want to know if somebody who's having trouble with sex with his wife is having marital difficulties. But you need to know, what's the question I need to ask now? What's going to make the biggest difference for my clinical judgment right now? And the answer is E. Do you wake up with erections? Okay, we're going to move on to another question, and then we'll come back and explain this. Question 3, so the patient says that he regularly wakes up with erections and is able to successfully attain an erection when watching pornography by himself. Which of the following is the best next step in this patient? A, referral for a full endocrine workup. B, hemoglobin A1C level. C, referral for cognitive behavioral therapy. D, brain and spinal MRI. Or E, penile ultrasound. Okay, so this should be fairly straightforward now. It's C. Okay, so what are we dealing with here? Psychogenic ED. Okay, so in my experience, anytime a young, healthy guy comes in complaining of erectile issues, 99 times out of 100, it's psychogenic ED. Okay, now if he were on sertraline, absolutely, I would be first thinking about a side effect of sertraline. But it would be very, very unusual, if not impossible, to have long-term residual effects from sertraline. Typically what happens with sertraline and with all of the other SSRIs is that they have difficulty, yes, potentially achieving an erection, but the bigger problem with sertraline and the SSRIs is anorgasmia. They have a difficulty climaxing. And that's not what we see in this patient. Now, the first thing that you want to know when any man comes in to the clinic saying, Doc, I have a hard time getting an erection, the very first thing you need to ask all the time is, do you get an erection in the morning? Or can you get an erection when you're watching pornography or when you're masturbating? And if the answer is yes, then you're almost certainly dealing with psychogenic ED. And you can try things like Viagra. You can try things like sending them off for sexual counseling therapy, i.e. cognitive behavioral therapy. That would be the best place to go. If the answer is no, then the next question you need to ask is, do you have a good libido? Do you feel sexual desire? If you've got a 30-year-old man who's coming in saying, I want to feel sexual desire, but I don't feel any, then you need to start thinking about hormonal problems. And that could be a variety of causes. It could be hypothyroidism. It could be a craniopharyngioma. It could be low testosterone. It could be hyperprolactinemia. There's a number of things that it could be. You would want to send the patient up for a full endocrine workup. But this patient doesn't have any problems with that. So we would get rid of A. Hemoglobin A1C, no, because this patient, again, has no signs of diabetes. Okay, he's not coming in peeing all the time. He's not coming in with changes to his vision. He's not coming in morbidly obese and, potentially have some kind of cryptic diabetes. So that's out. Brain spinal MRI, he has no neurologic symptoms. And a penile ultrasound, that could be useful if we were thinking maybe of a vascular disorder, although that would not be your first test anyway. So the answer is C. So erectile dysfunction has a number of causes. I have an entire video on erectile dysfunction. You can go watch that if you so desire. Vasculogenic is a common cause, but we would tend to see that in older patients. This is caused by a disturbed blood flow to the penis. It's usually due to an atherosclerotic cause. It is the most common cause of ED overall. Diabetic generally owes to vasculogenic or neurogenic causes. Neurogenic a lot of times is going to be seen in people with neurologic disorders, particularly MS. And then, that kind of can pertain to diabetes too. These both kind of fall into that. Medication-related, SSRIs are the most common, although I would say that even more commonly with SSRIs, especially with women too, what we run into is anorgasmia, so these patients can't climax. Thiazide diuretics can do it, very common. Beta blockers, very common, although SSRIs are probably the worst for it. Another one you'd think of is anti-androgenics, something like finasteride, which is commonly taken for male pattern baldness, 1 milligram, although it's the 5 milligram dosage that usually does it, and that's taken for BPH. Endocrine, like I said, I already kind of discussed that. And then psychogenic. So this guy had a history of generalized anxiety disorder, so he may already be an anxious person. And so this wouldn't be all that surprising. But there are a number of other psychogenic causes that can play into it. There are things like, yes, marital issues, relationship conflicts, maybe conflicts over sexual preference. Those are things that when he goes and sees a therapist for this, that they would talk about, but it would not be really a timely question for you to ask in the clinic. So here are some hints. Erectile dysfunction could easily come up as a CCS question, so I would expect to see that there. You need to know how to work these patients up. So some hints for vasculogenic: look for an older patient with a history of CAD, maybe a stable angina, maybe a limb claudication. Look for an abnormal vascular examination like Bruys. Diabetic, pretty obvious history of diabetes. This tends to have a gradual onset, as does vasculogenic. Medication related, the big hint there is they're going to give you an common offending medication like SSRIs, and the symptoms will coincide with the commencement of the drug. So they started the drug 2 months ago, the symptoms came on 2 months ago. Pretty straightforward. Neurogenic, look for MS, diabetic neuropathy, spinal injury, This can be really variable. It just depends on the cause. Expect to see focal signs or signs consistent with the underlying disorder. Endocrine, again, it's going to depend on the cause, but decreased libido is common because that is highly dependent on the sex hormones. And then psychogenic, the giveaway here is that these patients function fine outside of the sexual activity with somebody else. So they can masturbate fine. They have erections when they wake up. This is classic psychogenic ED. You run into it all the time. Look for a vignette with a young man. All right, let's move on to question number 4. We got a 26-year-old woman coming into the ED complaining of left-sided facial droop for the past hour. On physical exam, it's noted that she has a swollen and erythematous right calf. She's admitted to the hospital, started on heparin, and she gradually improves. While she was in the ED, a head CT was obtained, and you can see that on the right here. Which of the following diagnostic tests would most likely reveal the underlying cause of this patient's condition? And I'm just going to add here, she is on no medications and has not been on any medications besides the heparin. Is it A, duplex ultrasound of the left calf, B, 24-hour continuous cardiac monitoring, C, transthoracic echocardiogram, D, factor V Leiden genotyping, or E, bilateral carotid ultrasound? All right, so the answer is C, transthoracic echocardiogram. So what happened to this patient? Well, based on her presentation and her imaging, she had a stroke. And in particular, she had a right-sided MCA stroke, ischemic stroke in the MCA distribution on the right side. And so that is contributing, that is the cause of her left-sided facial droop. Now, why is a 26-year-old woman getting a stroke? We don't know. We don't know. Now, there are some likely causes. She had a DVT, but DVTs typically cause pulmonary embolism. So again, why do we think she had a stroke? There is one cause of stroke that you're going to see in otherwise healthy appearing people, and that is a paradoxical embolism, and it will generally be associated, for test purposes, always be associated with a DVT. And so the cause of a paradoxical embolism, or what allows you to have a paradoxical embolism, is a patent ductus arteriosus, which will be diagnosed on transthoracic echo. So how does this happen? So let's take a look at the anatomy of the heart. So the legs are going to be down here. And so what happens is that you have a DVT, the thrombus forms and dislodges, and it'll travel up the inferior vena cava here. And now, in most people, it'll enter the right atrium, into the right ventricle, and then go through the pulmonary arteries, and then eventually lodge somewhere in the pulmonary circulation. Now, if a person has a patent foramen ovale, what can happen is, yes, they can get a pulmonary embolism, but what can also happen is that the embolism, or embolus, can travel through the foramen ovale into the left atrium, and then through the left ventricle, and then up through the aorta, ultimately going to the carotid arteries. And that is, in fact, what happened here. It went to the carotid artery and then eventually to the MCA, causing the stroke. And so this is what happens typically in a younger person if they have a stroke. They have a DVT and a patent foramen ovale. So this woman, she clotted for some reason, which we don't know, but nonetheless, she clotted and had this DVT and a paradoxical embolism. Now, typically, if somebody has a DVT, they have some risk factors. They could have a hypercoagulability disorder. They could be on oral contraceptives and a smoker and have multiple risk factors that lead to a DVT. Now, we don't know about it in this patient because often on the USMLE, they're not going to give you the dead giveaway. But you need to know that if a young person has a stroke and they have a DVT, the likely explanation almost certainly is going to be a patent foramen ovale. We do not know if a patient has a patent foraminovalle, because typically it doesn't even cause a murmur. So it's usually asymptomatic, and the first we will realize it is if we're doing an echo for some other reason, or if a patient presents like this. Like I said, there's typically no murmur, it's asymptomatic. That foraminovalle should close upon birth when you take your first breath, but it doesn't necessarily close all the way in everybody. And so the best way to diagnose that patent foraminovalle and to know that that's what happened is via a transthoracic echo. So why is A wrong? Duplex ultrasound of the left calf. That's not going to tell you anything. We know she had a DVT and it was on the right side. By looking at the left side, it's not going to tell us anything. So that's out. 24-hour continuous cardiac monitoring. This can lead to an embolism, but you would have to have AFib. There's no suggestion in this patient that she has AFib. Typically, AFib will come from valvular heart disorders, ischemia, multiple reasons why you can have AFib, but it tends to be in older patients. So that is out. Factor V Leiden genotyping. That would be something we would want to investigate in this patient. Factor V Leiden is the most common thrombophilia, inherited thrombophilia, but this is not the cause of the embolus. It contributes to the risk factors, but it is not the cause. And we want to know what's the underlying cause, and that is the patent foraminovalle. If she did not have a patent foraminovalle, she would have had a pulmonary embolism. So that's out. And then bilateral carotid ultrasound, that is useful for patients with transient neurologic signs. And these are usually going to be older people. They have some atherosclerosis of the carotids, and we can look at the carotids that way. But it's highly unlikely that an otherwise healthy 26-year-old is going to have atherosclerosis of her carotid arteries. So that is out, leaving the transthoracic echo. Okay, question 5. We've got a 44-year-old woman coming into the clinic complaining of fever, malaise, and cough for the last 5 days. She says that she had something similar to this 3 years ago when she forgot to get her flu shot, but she says she got her flu shot this year and doesn't understand why she's feeling like this. She has a past medical history of Crohn's disease, which is currently managed with methotrexate. She does not drink or use recreational drugs. She's unaware of sick contacts. Physical exam reveals mild cervical lymphadenopathy and a hyperemic pharynx with no exudates, but is otherwise normal. Vital signs are within normal limits, but she does have a mild fever. Based on this patient's presentation, which of the following courses of action will be of most benefit to this patient? A, adjust the dosage of methotrexate. B, begin oseltamivir and acetaminophen. C, begin oseltamivir and ibuprofen. D, acetaminophen alone. Or E, begin azithromycin. So this is a question that is asking you to make a presumptive diagnosis. It expects you know that, and then know the course of action that you need to take. All right, so let's look at the answer here. It's D, acetaminophen alone. What does this patient most likely have? Based on the fact that she has a cough, it is unlikely that she has strep throat. She doesn't have any of the exudates. She has a cough. You typically don't see that in strep throat. Yes, she has a fever, but this is more than likely influenza. Now, can you get influenza after a flu shot? Absolutely, you can. It's much less likely, and we recommend everybody get a flu shot before the winter months when the shot comes out. But you can still get the flu. And so if a patient comes in and they have flu-like symptoms, regardless of whether they got the flu shot, you need to test them for it. And so that is important. Now, would we test this patient? Yes, of course we would, if this were real life. But it's asking you to make a presumptive diagnosis, and then it's asking you what would you do, okay? So she's got the flu, and she has had it for 5 days. All right. Now, when can we use an antiviral for the flu? it needs to be within 2 days of symptom onset. So she cannot receive, well, she can, but it's not going to be of any benefit to her to receive an antiviral like Tamiflu or oseltamivir. And there are other drugs, but we'll just say oseltamivir here. So it's not going to be any benefit. So B and C are out. Methotrexate, you can adjust it, but it does not cause the flu. So that is out. And azithromycin would be a great drug to give if she had strep throat, which she does not. She does not fit the criteria for strep throat, so that is out. So when a patient has the flu and they're beyond the window where they can receive Tamiflu, it is just supportive therapy. It's just supportive therapy. Take the acetaminophen or take ibuprofen. It doesn't matter for your fever, for the pain, but otherwise, that's all we do. You just ride it out. So influenza is an acute viral infection of the upper and lower respiratory tracts caused by one of the influenza viruses. It's most common in the winter months. I would say up here in the northern hemisphere, you're going to see it from October to March, roughly. Okay. In the southern hemisphere, it'll be the opposite. It'll be their winter months. Symptoms are pretty nonspecific. They're the flu-like symptoms: fever, headache, myalgia, cough, and sore throat. The major differential here is if they do present with sore throat as a salient symptom, then you need to exclude strep because the treatment will be quite different. And certainly we need to treat strep to mitigate the risk of post-streptococcal complications like glomerulonephritis. The diagnosis may be made clinically. However, there is a test that you can get. It's a PCR. You do a throat swab, send it off. Takes a couple hours for it to come back. On CCS, it'll be called influenza A and B titer, not PCR. That's currently what CCS calls it. The treatment we talked about, it's within the 2-day window. You can do oseltamivir. If it's after 2 days, then we do not. So that is the main thing I want you to get here. That will get asked. Complications, the major one is secondary bacterial pneumonia. There are certain people who are at higher risk, particularly elderly people, but also nursing home residents and pregnant women up to 2 weeks postpartum, and certainly people who are immunosuppressed. What happens there is they're at higher risk for pneumonia and they get a bacterial pneumonia, which if they come in and they're running a really high fever, they're not recovering, you start to hear crackles in their lungs, get a chest x-ray, you'll diagnose a lobar pneumonia, and then at that point, typically, because they are older, have these risk factors, they will need to be hospitalized. You'll put them on azithromycin and ceftriaxone. If they don't need to be hospitalized, if they're younger, otherwise healthy, you can just send them home on azithromycin PO. Question 6. A 27-year-old man presents to the clinic complaining of diarrhea for the last 8 months. He describes himself as otherwise physically healthy. He's tried cutting both gluten and dairy from his diet, but the diarrhea persists. He has 5 to 6 watery stools every day. He says that the episodes are accompanied by pain, which is relieved when he has a bowel movement. Vitals and physical exam are unremarkable. Rectal exam reveals a small amount of loose light brown stool, which is guaiac negative. Based on the most likely diagnosis, which of the following recommendations will be of most benefit to this patient? A, budesonide, B, loperamide, C, methotrexate, D, increase fiber intake to 35 grams per day, or E, linaclotide. Okay, so what does this patient have? So the answer is B, loperamide. What does this patient have? He has irritable bowel syndrome, and we know that based on the Rome criteria, which I will show you in a little bit. So what are these drugs for? Budesonide. Budesonide is the steroid of choice for treating inflammatory bowel disease. And why is that? Here's just a little pearl for you. This could come up on your test, especially if you're taking step 1. Budesonide is an oral steroid that you take, and it does get absorbed, but as it goes to the liver, it is quickly detoxified. And so the nice thing about that is that you are much less likely to get systemic effects of the steroid. And so it'll only be acting in your gut. And so that is a great steroid for treating IBD, inflammatory bowel disease, either Crohn's or ulcerative colitis. But that is not what this patient has. This patient does indeed have a chronic diarrhea. However, there is no blood. He does not have any systemic signs, and that is a sine qua non for IBD. I'm sorry, IBS. If you don't have systemic signs, you're not running a fever, you're not losing weight, none of that, it is highly unlikely that it's going to be ulcerative or Crohn's. So that's out. Methotrexate, again, it's a DMARD. It's used for IBD, so that's out. Increased fiber intake. So we might recommend that he try to increase his fiber intake. 90% of Americans are deficient in fiber. It can help with both diarrhea and constipation, but we would probably not recommend 35 grams. The general recommendation is 20 to 25 grams. So that would be going way overboard on fiber, probably wouldn't make him too comfortable. And then linaclotide. Would we use linaclotide in IBS? Yes, but we would use it for constipation, not for diarrhea. This guy has IBS-D, so we would use loperamide. That is the drug of choice for IBS-D. Irritable bowel syndrome is a diagnosis of exclusion. It is a big cause of chronic diarrhea. It is always painful, and it is never bloody or fatty. So you would not expect this guy to lose weight due to malabsorption, and you certainly would not expect constitutional signs because this is not an inflammatory process. Risk factors, female gender, sexual abuse, fairly loosely correlated. It's about 2 to 1, female to male, so it's not a huge preponderance. Like I said, diagnosis of exclusion, you need to rule out other causes. You could get stool studies on this guy. Certainly, if this were a CCS case, go ahead and order stool studies because we want to exclude other potential causes. He could have celiac disease. That is possible. But the vignette says he cut gluten out of his diet, and you can believe him on a test question. Now, I will say that it is very difficult to exclude gluten from your diet. Some people think that just means cutting bread out of the diet, but there are a number of other things that contain gluten. I've got a friend who's got celiac disease. He can't even eat barbecue sauce because it's got gluten in it. And so it's very difficult. A patient may say they cut gluten out of their diet, but in fact they didn't. And so some education may be worthwhile. You might get titers, anti-TTG, go for it. However, celiac disease tends to cause a malabsorption. So if you were to get stool studies, it would show fecal fat globules, and you would expect this guy to have lost some weight. My friend that is celiac was rail thin. He got diagnosed with celiac, went on a gluten-free diet. Guy gained like 80 pounds. He's a fatty now. No offense, but he gained a lot of weight. So that was celiac. You can get a workup. You should get a workup, CBC, anti-TTG, fecal calprotectin, and then other workup based on symptoms. But again, this is not a likely diagnosis in this patient simply because he has not lost weight. The treatment is individualized based on the symptoms. I am not going to go into all of these. I have a whole video on IBS, but the first line therapy for IBS-D is loperamide. There are a number of other drugs that can be used. And then you can see I go into some of the other ones here. TCAs can be used. Antispasmodics can be used. That is primarily looking at treating the pain. So these are the Rome criteria here. You can look up more on that if you want, or go back and watch my video on IBS. Question 7. We got a 22-year-old man coming into the clinic complaining of worsening lower back pain for the past year. He initially believed that this was due to his job as a postal employee, which required him to lift large packages. However, he quit that job 6 months ago and now works a desk job, but the pain has continued to get worse. He says that the pain is worst in the morning and improves throughout the day. He has no significant past medical history. He takes ibuprofen daily for the pain, which he says barely helps. Family history includes rheumatoid arthritis in his mother and back arthritis in his father, which began when he was in his 30s. Physical exam reveals limited range of motion of the lumbosacral spine. The remainder of the physical examination is unremarkable. Vitals are within normal limits. Which of the following is the best next step in the management of this patient? Is it A, lumbar spine MRI, B, lumbar spine X-ray, C, ANA, D, rheumatoid factor, or E, HLA-B27 antigen? So once again, another question that is requiring you to know the diagnosis, the presumptive diagnosis, and know what to do next. Step 3 loves to skip that step. All right, so the answer is B, a lumbar spine x-ray. What does this guy have? Most likely. Okay, so this guy most likely has ankylosing spondylitis. Why? Well, he is a man. Men tend to get ankylosing spondylitis more than women do. He's got lower back pain. Should young men be getting lower back pain at 22? No, he's a little too young to have those aches and pains that we expect to see in 50 and 60-year-olds. The big hint here, though, is that it is worst in the morning and improves throughout the day. That is so typical of an inflammatory bone or joint process. So things like rheumatoid arthritis and stuff like that, where they're stiff in the morning and it gets better throughout the day, but it worsens as time goes on. Now, the fact that he has RA in his family may be an indication to, check a rheumatoid factor. Maybe it's that, but this would not tend to present in first of all, it's unlikely to present in a man, period. Men tend to not get RA. It's much more common in women. But he would likely be experiencing other joint symptoms, particularly of the fingers and wrists. RA tends to not present in the lower back. When you hear a patient have lower back pain, a young man with lower back pain, your brain should instantly go to ankylosing spondylitis and get that x-ray. So it is the x-ray that we get. If the x-ray were to come back negative, then we would, and we still believe that this is likely ankylosing spondylitis, then go for your MRI. So MRI would be second line if you cannot make the diagnosis on x-ray. ANA, probably not going to help you. That would be something we would think of if this were joint pain, possibly related to lupus. That is something that, again, does not tend to happen in men. But could you order it as part of your workup on CCS? Sure, why not? Throw it in. But this is not going to help you. Rheumatoid factor we talked about. HLA-B27 antigen. So this is a seronegative spondyloarthropathy, and there are many others like psoriatic arthritis. This is not a very sensitive or specific test. However, if you, let's say that you got the x-ray, but you don't quite know, you get the MRI and you don't quite know, it's equivocal, HLA-B27 may lend credence to the diagnosis of ankylosing spondylitis, but it certainly would not be your first step. So it is a lumbar spinal x-ray. Ankylosing spondylitis is an inflammatory disorder of the axial, skeleton, and the peripheral joints, so it's truncal. It is distinct from a lot of autoimmune diseases in that it's predominant in young men under the age of 40. Men are affected more than women by about 4 to 1, so a pretty significant male preponderance. Think of chronic, refractory lower back pain several months to several years, and it's worst in the morning and improves throughout the day. I cannot stress that enough. If you've got a patient with joint pain that's worse in the morning and gets better throughout the day, think of an inflammatory joint pain. Physical exam, you'll see a loss of lumbar lordosis and a loss of range of motion in the lumbar spine. What would we see on x-ray? You'll see fusion of the spinal processes, fusion of the sacrum. It's this classic bamboo spine. If you get an anterior-posterior view, you'll be able to see the bamboo spine. You can look up pictures for that. I have a whole video, by the way, on the seronegative spondyloarthropathies in my rheumatology. Okay, we are in the home stretch. Let's move on to question 8. We have a 58-year-old woman coming into the clinic complaining of fatigue, malaise, and bloody, well-formed stools for the last 4 days. She has never had this before. She's got a past medical history of chronic kidney disease secondary to long-standing IgA nephropathy, which necessitated dialysis for 6 years. 5 months ago, she received a kidney transplant. Medications include tacrolimus, mycophenolate, prednisone, and supplemental calcium and vitamin D. She's otherwise healthy. Physical exam reveals a diffuse, mild abdominal tenderness. Rectal exam reveals a small amount of dark brown guaiac-positive stool. Vitals are within normal limits. CBC is significant for normocytic anemia. BMP shows a creatinine of 1.6 milligrams per deciliter. Stool studies are negative for fecal fat. She is referred to gastroenterology for colonoscopy, which reveals multiple large, shallow ulcers throughout the colon. Which of the following is the most likely diagnosis in this patient? Is it A, cytomegalovirus or cytomegalo infection, B, bacterial dysentery, C, ulcerative colitis, D, graft versus host disease, or E, Epstein-Barr virus infection. Okay, so who is this patient and what does she have? She's got a cytomegalovirus infection. This is a complicated one. It's complicated because this patient is on medications that cause immunosuppression. And so there are a number of things that can happen. Now, what are her chief problems? Well, yeah, fatigue, malaise, but this bloody, well-formed stools. So she's got bloody stools, indicating possible ulceration or inflammation of the colon. And she's on a number of drugs that are immunosuppressive: tacrolimus, mycophenolate, and prednisone. All three of those are going to impair your immune system. So what do we expect then? Increased likelihood of infections. So you need to be thinking that. Now let's go ahead and look at our list here. So we'll skip CMV for now. Bacterial dysentery, why not? Well, with bacterial dysentery, we would expect to see diarrhea. Okay, so we're talking here like Salmonella and Shigella and EHEC and bacteria like that. So we would expect to see diarrhea. We would also possibly expect to see sick contacts. You usually get it from food. And so other people that she may have been around may be having the same thing. We don't see that here, so we'll get rid of that. Ulcerative colitis. What would we expect to see with ulcerative colitis? Well, first of all, this patient's history is not congruent with ulcerative colitis. Typically, you don't get ulcerative colitis at this age. It's something that will typically develop in your 20s or 30s, maybe your early 40s. It can develop at any age, but it tends to develop in adolescence and early adulthood. 30s and 40s are really pushing it. With ulcerative colitis, we would also tend to see a different pattern of lesions, more deeper lesions perhaps. We would also expect to see some degree of fat malabsorption potentially, or at least weight loss, because this is a chronic inflammatory disease. So that is probably not it. Graft versus host disease, why not? Graft versus host disease is usually seen in people who have gotten stem cell transplantation, like a bone marrow transplant. And then what happens is that those bone marrow cells recognize the host as foreign. And so various tissues in the body will be attacked. Usually these patients will start out with a rash. And so this patient does not fall into those risks. And then what about an Epstein-Barr virus infection? So Epstein-Barr virus infections can be opportunistic, and in those cases, they're usually associated with malignancies like a non-Hodgkin's lymphoma, for instance, but they are not associated with colitis. Now, one of the things that they could throw in there to help you, but I did not include it because I wanted to make this a little more challenging, was they could throw in there with the CBC atypical lymphocytes. Now, for the most part, if you see atypical lymphocytes, what you should be thinking is either an Epstein-Barr virus infection or a CMV infection. So when you go, if you think you have mono, they take your blood, they look at it under the microscope. If they see those atypical lymphocytes, it's almost certainly an Epstein-Barr virus infection. However, let's say you do an Epstein-Barr virus test and you still have atypical lymphocytes, then it may be CMV. It can cause an almost identical syndrome. They both look like mono. Okay, so atypical lymphocytes associated with these two. So you would have it down between these two, but as I said, Epstein-Barr virus typically does not cause colitis. And so the answer here is cytomegalovirus infection. Now, this can happen in all sorts of immune-deficient patients, including people with AIDS. So it is not just in people on immunosuppressant drugs. Basically, in some sense, we're kind of inducing an AIDS in this patient, a controlled AIDS, if you will. These are some of the drugs used in renal transplant patients. I am not going to go through all of these, but what I want to point out is she's on this one, she's on this one, and let's see, what else was she on? tacrolimus, and mycophenolate, right? So this reduces T cells, this reduces T cells, and this decreases T cell activity. So she is immunosuppressed, particularly those T cells. And those T cells are responsible for fighting off viruses and also some fungi. So then what we're left here is something that looks fairly familiar. It looks a lot like what you would see in sort of the opportunistic infections that we run into in AIDS. So oral candidiasis, for instance, pneumocystis carinii, cytomegalovirus. Let's see. I think I got to most of them. So there are a number of there's quite a bit of overlap. Let's just put it this way. And the reason that there's overlap is because we're going after the T cells, and that is the same cells that the HIV virus goes after. So you see quite a bit of overlap. You don't need to memorize this in terms of, less than a month, 1 to 6 months, more than 6 months. As long as you know how these syndromes manifest, you will be good. All right, let's move on to question 9. We got a 45-year-old woman presenting to the clinic complaining of worsening fatigue, weakness, nausea, and abdominal pain. You notice immediately on her chart that she's lost 15 pounds since her last visit last year, which she says was not intentional. 3 weeks ago, after similar complaints of weakness and lightheadedness, she was found to have a low serum cortisol and very little response to ACTH stimulation. She was discharged on PO hydrocortisone. Since then, she has continued to have occasional dizziness and nausea, but her appetite is better and her abdominal pain has resolved. On physical exam, you note a blood pressure of 115/72 laying down and 96/59 while standing. The remainder of the physical exam is unremarkable. Other labs are obtained and shown. Which of the following is the best next step in the management of this patient? A, add midodrine. B, brain MRI. C, decrease hydrocortisone dosage. D, increase hydrocortisone dosage. Or E, add fludrocortisone. All right, so here are your labs. You can take a look at those. And this is a 2-part question, by the way, so I'll give you the answer. We'll move on to another question, and then we'll give you some explanations. Okay, so the answer here is E, add fludrocortisone. Okay. After beginning fludrocortisone, you follow up with the patient 2 months later, and she thanks you for curing her symptoms and brings cookies to show her appreciation. These are extra cookies because her appetite is back and she's gained back all the weight, and probably then some, that she lost while she was sick. She does want to know what her diagnosis is, however, because nobody has ever told her. That is really common, by the way. She's a former science teacher and wants not only to know what the diagnosis is, but which organ was affected specifically and how. Meanwhile, you note some things on her that you did not notice last time. What do you tell her? And I'm going to show you the things that you noticed now that you didn't notice last time. This. Okay? You notice this. Okay. So let's go back. What do you tell her? A pituitary tumor reducing ACTH secretion. B, autoimmune attack on the adrenal glands. C, hemorrhage into the adrenal glands. D, cancerous spread into the adrenal glands. E, necrosis of the pituitary gland. Okay, so our answer here is B, an autoimmune attack on the adrenal glands. What does this patient have? Addison's. She's got Addison disease. How do we know that? Well, based on her lack of response to the cosentropin or ACTH stimulation test, we know that she has a primary adrenal insufficiency, and there aren't that many causes of that. There are 3 listed on here. It could be autoimmune. It could be due to a hemorrhage, such as like a Waterhouse-Friderichsen syndrome, which she would probably know already if she had that. That also tends to be very fulminant and life-threatening. Or a cancerous spread into the adrenal glands. That could be from like a renal cell carcinoma. Again, something she would probably know that she had. You can also get TB infiltration into the adrenal glands, but that's obviously really rare. Autoimmune attack on the adrenal glands, autoimmune adrenalitis is the #1 cause of primary adrenal insufficiency. These others, pituitary tumor reducing ACTH secretion, in that case, we would expect a response to ACTH because there's nothing wrong with the adrenals. So we would expect to see a response, and then we would go ahead and get a brain MRI and whatnot. Necrosis of the pituitary gland, that's Sheehan syndrome, and typically that happens after you deliver a baby. So in that instance, yes, we would see these symptoms, but we would see a whole lot of other symptoms. We would see a change in her menstrual cycles because of low LH and FSH. We would expect to see hypothyroidism and a number of other things. So that is not it. And, it could have been any of these three, but they're asking you to pick the most likely one, and that is B. Now let's go back here briefly. And why do we add fludrocortisone? Why did we need to add fludrocortisone? We were giving her hydrocortisone, and that works for replacing cortisol, but it doesn't work for replacing the mineralocorticoid aspect. That needs to be replaced as well. So when you have a primary adrenal insufficiency, you need to replace both so that you are replacing your cortisol and you are replacing your aldosterone. The fact that she got a little bit better, but she is still having this orthostatic hypotension, her sodium and potassium were off, she had a low sodium, high potassium, those are indicators that you have a mineralocorticoid deficiency or a hypoaldosteronism. And so you need to fix that as well. So we do both. And by the way, Mitidrin, it used to be used for dysautonomia, for orthostatic hypotension deriving from that. It is not used anymore. It has been taken off the shelf because it has been associated with cirrhosis. So I included that in there, but you will not be using that drug. Doesn't mean it can't come up as a wrong answer choice, though. So primary adrenal insufficiency is an inability of the adrenal gland to make hormones like cortisol and aldosterone. The number one cause is autoimmune, i.e. Addison's disease. It can also be due to infection or metastatic infiltration. The manifestations will relate to the hypocortisolism and the hypoaldosteronism. And then in Addison's, the high CRH, high ACTH, which leads to hyperpigmentation. We'll get to that in a little bit. So low cortisol is going to make you feel tired and sluggish and weak and can give you some abdominal pain. Low aldosterone is going to make you salt craving. It's going to make you volume depleted. It's going to make you dehydrated, and you'll have that orthostatic hypotension due to the volume depletion. Labs will show hyponatremia, hyperkalemia, and due to the autoimmune nature of it, eosinophilia. To diagnose this, you do an ACTH stimulation test, and you'll see no increase in cortisol because it's the adrenals that are the problem. If it was the pituitary that was the problem, wasn't making ACTH, then if you give cosyntropin or synthetic ACTH, the adrenals will respond and you will have a response. So it's our way of distinguishing whether this is a problem with the pituitary or a problem with the adrenal gland. The treatment is to give both a glucocorticoid and a mineralocorticoid. This is my algorithm that I use when I suspect adrenal insufficiency. So the first step is to do the cosyntropin stimulation test. If there's no response, you know the problem's in the adrenals. And if it's an acute thing, usually this is a very fulminant presentation. You don't need to do a workup. Then it's Waterhouse-Friderichsen syndrome. If it's insidious, like it was in this patient, it's more than likely Addison's disease, but there are a number of other rarer things that it could be due to. If, on the other hand, you have a normal response, the cortisol goes up, then you know that the problem is in the pituitary or possibly the hypothalamus. At that point, you're going to get levels of all the pituitary hormones, and you're going to do a pituitary MRI. If all the levels are low, then it's a panhypopituitarism. The big one here is Sheehan syndrome, particularly if she just gave birth, but there are a number of other causes too. If only ACTH is low, we call that an isolated ACTH deficiency. It's fairly easy to treat these patients. We just give them synthetic ACTH. And if you have an abnormal MRI, now you're looking at a potential surgical issue. So Addison's disease was the diagnosis in this patient. Really, this is just preventative. We replace the missing hormones. The goal is to keep the patient out of an adrenal crisis. That is very, very important. Both glucocorticoids and mineralocorticoids need to be replaced. This is different from if it were secondary. So if it was a pituitary problem and you are you're simply not making ACTH. The adrenals will still be able to respond and make aldosterone through the direction of the renin-angiotensin-aldosterone system. So aldosterone is typically intact when it's a pituitary problem. But if it's the whole adrenal gland, then you're going to lose both mineralocorticoids and your cortisol too. So both mineralo and glucocorticoids. Hopefully that makes sense. Now, one thing I do want to point out here is that when you have a primary hypoadrenalism, primary adrenal insufficiency, what's going to happen is you're going to have a loss of negative feedback to the hypothalamus. That's going to result in CRH from the hypothalamus, and that will trigger from the pituitary something called POMC. I can't remember what that stands for, but you can look it up. It doesn't matter. Now, this will break off into a melanocyte stimulating hormone and ACTH, the same one we all know and love. This will go to the adrenal. Now, if all this is elevated, you'll have an elevated MSH, and that's going to lead to hyperpigmentation, and that's why we get that manifestation. That's kind of a step one question. So all these patients should wear a medical alert bracelet indicating that they have Addison's disease, because if they're unresponsive and they need to go into surgery, the surgeon, the anesthesiologist is going to need to know that they need hydrocortisone stat because they can go into an adrenal crisis. Patients should be advised if they get sick to increase their dosage of prednisone if they're either ill, even something so much as a common cold, or if they're under stressful or painful situations like getting a tooth taken out or high psychological stress even, they may need to increase their dosage. You don't need to worry about figuring that stuff out. Their endocrinologist will give them all the deets on that. Failure to do so can precipitate adrenal crisis, which can be deadly.